Hello everybody! I would like to present some recent research on a quite specific type of victimization of older care-dependent persons, namely resident-to-resident aggression in institutional care. My name is Thomas Görgen and I am a criminological researcher from German Police University in Münster, Germany. This is my agenda for the next 20 minutes. I will say a few words about the quantitative dimensions of care for older adults in Germany. I will then briefly address the somehow and somewhat incomplete discourse on violence and abuse in caregiving. I will provide some examples of resident-to-resident aggression cases that have been taken to German criminal courts. I will then present our study, which ran under the acronym of RAIL, which stands for Resident Aggression in Long-Term Care. I will speak about the methodological approach that we had chosen and will present some selected findings. And in the end, I will come to a few conclusions. Looking at the current dimensions of nursing care in Germany, nursing care which is mostly, though of course not exclusively, care for the elderly, you can see that there are now more than 4.25 million care recipients. Care recipients meaning people who draw benefits from our mandatory long-term care insurance system. As you can also see, the focus of German elder care is not on care in nursing homes, is not on care in institutions, but on family caregiving. There's also a strong political emphasis on caregiving within the family. And in numbers, we can say that there are currently about 3.34 million care recipients who are being cared for at home in domestic settings by their family members, by staff from in-home care services, by combinations of both, which at the same time means that there are only, but still amounting to more than 900,000 persons, only slightly over 20% of care recipients who are being cared for in residential facilities in nursing homes. In Germany, there are currently over 14,000 in-home care services providing services in the domestic environment, and an even slightly higher number of nursing homes providing institutionalized care. Domestic care services and nursing homes together employ around 1.15 million people. In Germany, as in other countries and regions of the world, there is some degree of discourse on abuse and violence in caregiving contexts. If we look at this discourse, we can see that it usually focuses on one specific type, and that is abuse and neglect of older care recipients by caregivers, be it professional, be it private. In Germany, we have had some really high-profile cases, such as that of a male nurse who killed dozens and maybe even hundreds of mostly older patients, although this specific latter case occurred mainly in hospitals and therefore not in the strict sense of the word within care facilities. The issue of patient aggression against staff is also, to a certain extent, the subject of public and professional discussion, particularly with regard to dementia patients. However, this does not exhaust the full range of victim-perpetrator constellations if we describe them as such in institutional care for older adults. This figure wants to show in a very simple way the range of victim-perpetrator constellations in nursing homes. If we look only at residents on the one hand and at nursing staff on the other hand, so exclude all the other groups that may be present in nursing homes, we get a 2-by-2 constellation of aggressors, of perpetrators, however you want to call them, and of persons being the victim of attacks, becoming victims of aggression. As we can see, both groups, nurses and residents, can appear as aggressors as well as attacked, and the attacks can be directed at members of the other groups, but also at one's own group. While our focus, the focus of public discussion, the focus of research, is usually on violence by caregivers towards people in need of care, which is here the square marked with C and with the small red circle. This is the topic of elder abuse and neglect. I would today like to take a look with you at the two squares on the right, which deal with aggressive behavior by residents in nursing facilities, aggressive behavior towards caregivers, but especially towards fellow residents. I will be speaking about resident-to-resident aggression between residents, which is often abbreviated by RRA, and I will also speak a little bit about resident-to-staff aggression, aggressive behavior of people living in nursing homes towards staff, which is frequently abbreviated as RSA, and I will also sometimes use these two abbreviations. Before I come to our own study, I want to sketch a few examples of cases of aggressive behavior between people living in German nursing homes. These cases, they are not everyday cases. They are not representative of the universe of resident-to-resident aggression, but they are cases that have gone to criminal courts. So we can say that they certainly represent the upper end of a possible severity scale. They show what is possible in the realm of resident-to-resident aggression. The first example, a female resident, 88 years old at the time of the incident. She killed her 86-year-old female roommate by slaying her with a glass bottle, an everyday object that was present there, a mineral water bottle. When she was interrogated, that woman, she said that she had been disturbed by the victim's constant verbalization, by the victim's constant screaming, the woman she shared her room with. Second example, a man, demented and psychotic, 73 years of age. He attacked two sleeping female co-residents who were sleeping in another room, 76 and 86 years old. He attacked them with a metal bar, a solid metal bar that he had removed from his bed. In the course of the events, he also attacked a female nurse who then, in self-defense, locked him up in the room with the two women until the police arrived. The two women died as a result of the attack. By court order, the man was placed in a psychiatric institution. My third and last example, a 64-year-old man was caught sexually assaulting a 68-year-old paralyzed woman in her bed. Investigations revealed that this had happened repeatedly due to mental disorder. The court judged him again as lacking criminal responsibility. I will briefly outline the study we did on resident-to-resident aggression in long-term care. Our research was funded by the German Federal Ministry for Family Affairs, Senior Citizens, Women and Youth. We, that is German Police University, conducted the study in close cooperation with the Center for Quality in Caregiving in Berlin. The main aim of the study was to analyze the phenomenon of aggression among nursing home residents and its relevance for nursing care and nurse education. Thereby, our main focus was on RRA, on resident-to-resident aggression, but we also had a secondary focus on resident-to-staff aggression, RSA. Methodologically, we combined different strands. We did a quantitative survey in 73 German nursing homes with a sample of more than 1,300 staff. We did qualitative interviews in a small sample of 4 selected nursing homes with 21 residents and 56 staff members. And additionally, we conducted 10 interviews with experts from relevant fields of work. This table sums up some key data from our survey among more than 1,300 employees. What does it show? We asked employees about incidents of resident-to-resident aggression they had witnessed, and we asked them about aggressive behavior by residents directed against them. And we asked for both areas, we asked, did that happen within the last 4 weeks? And we also asked, has that ever happened since you joined this institution? So we have two types of prevalences for RRA and for RSA. One refers to the last 4 weeks, and one refers to the time since that person joined the institution. What we can see on this slide is that in the last 4 weeks, 2 out of 3 respondents had experienced aggressive behavior from residents directed against them. And we can also see that 3 out of 4 had witnessed aggression between residents. In both fields, we can see that experiences of verbal aggression were more common than physical aggression, and sexually aggressive behavior ranked last in quantity. For resident-to-resident aggression, we also included questions on behaviors like unwantedly going into another resident's room, taking away things, maybe destroying a property belonging to another resident. This is what you can see on this slide as violation of personal space and private property. This was also frequently reported by, for the last 4 weeks, by almost half of the respondents. If we summarize some more findings from the quantitative survey, we can say that staff really frequently experience and observe aggressions by residents, and we can say that verbal aggression in particular is quite common and widespread. We also found that qualified nursing staff report more resident-to-staff aggression and more resident-to-resident aggression than people who are only care assistants. There is quite a clear connection and correlation in the range of 0.40 between experiencing resident-to-staff aggression and observing resident-to-resident aggression. To a certain extent, we can say that the encounter with aggressive and violent behavior by residents is part of the everyday work experience in caregiving institutions. This applies both to incidents directed against the person oneself, the staff member, and this applies also to behaviors observed by that person between residents. We also asked employees about characteristics of the most recent episode, the most recent incident of resident-to-resident aggression they had witnessed. We asked them what did happen when you last witnessed that one resident behaved aggressively towards another, or where did that happen, who were the persons involved, what were their characteristics, what do you think may have been the causes or triggers, how did you or how did your colleagues react. In this way, we collected data on over 800 RRA episodes. What do these incident descriptions reveal? First, they reveal that the incidents observed mostly started in shared rooms, that is, in dining rooms, hallways, common rooms, etc. Only 12% originated in residence rooms. Of course, this also has to do with observability. The staff we surveyed, they had better chances of observing incidents that took place in common spaces, but it also has to do with the fact that those shared spaces, they have a lot of potential for conflict about use of space, about different interests getting together or meeting on a small and limited space. Again, in these episodes that were described in the study, verbal aggression was most common. It was present in 71% of the episodes, but there was also physical violence present in 41% of the reported cases. we found that males and relatively younger residents, relatively younger meaning those below age 80, were overrepresented among what we called initiators. You might also call them the perpetrators of aggression. On the other hand, targets or victims of aggression had more restrictions in mobility and more restrictions in speech than those initiators. Cognitive loss, severe cognitive loss, was present in both groups at around 60%. When asked about factors that may lead up to such aggressive episodes, respondents often attributed them to some kind of conflictual interaction between residents and to residents' restricted capacity to communicate and to understand, to correctly understand and interpret social situations. We also asked about staff's reactions to RRA incidents. Their short-term measures mainly aimed at cooling down the situation by separating involved residents, by calming them down, and by distracting their attention from the conflict. Long-term measures related to organizational changes such as offering places of retreat or increasing residents' inclusion involvement in leisure activities. As far as prevention and management of resident-to-resident aggression is concerned, our survey and our interview data, they show that very little specific training on how to handle RRA incidents has been provided so far, although there is some training overlap with the issues of challenging behavior and of dementia care. We found that the way staff deal with RRA issues is mainly reactive. It aims at averting immediate risks, usually by separating opponents. In doing so, employees act under time pressure and they act with little strategic analysis of triggers and of risk factors. Prevention and successful management of RRA problems could benefit from more specific training of staff on RRA topics, on de-escalation, on violence prevention. It could benefit from the implementation of specialized and specially trained RRA contact persons in facilities. It could benefit from the implementation of institutional routines and guidelines relating to the topic. Approaches like the design or redesign of the physical or architectural environment in order to avoid overcrowding, to avoid stimulus overload and other stressors can be important as well. Last but not least, there was a broad consensus among those we asked that improving staffing levels in care facilities would not only be beneficial to the overall quality of care provided there, but would also specifically be beneficial to the prevention and successful handling of resident-to-resident aggression. I will end with some conclusions. RRA, we found, is a really common experience in residential care facilities. It has some overlap with what is known as challenging behavior or challenging behavior in dementia, but at the same time, it is a problem in its own right. Prevention of resident-to-resident aggression requires multifactorial strategies, including attempts to increase awareness and problem recognition, to change the physical environment in order to reduce stress and conflict, to provide specialized education and training for staff, to establish institutional routines and policies such as guidelines on resident-to-resident aggression, specialized contact persons among staff, discussing RRA incidents in the frame of case conferences. And it has to improve staff-patient ratios. According to our findings, the preventive potential of specialized dementia care being care that is done in specialized departments, should also be considered. These were a few results from our pilot research on resident-to-resident aggression that we conducted in German nursing homes and have just finished. I thank you very much for your attention and hope to see you at another conference in Prague. Thank you very much.